Anurag Mishra. He'll be talking about nucleus management in presence of a small pupil.
Thank you so much, Arban sir, for the kind opportunity. Good morning, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. The advent of new techniques and technologies, and of course the skill enhancements that we have incurred in the last decade or so, has actually converted this small pupil, which used to be a menace for us, into something very, very naive. And we are going to discuss how naive is naive and how small pupils have stopped to bother us altogether. Before going into that, what are the manifestations of a small pupil? The geometry is altered, it's become small. Due to the presence of several comorbid factors, the increased permeability happens of blood-aqueous barrier, and that causes an issue in the post-operative period. Particularly, you have to manage AC reactions more. There is a possibility of trauma to the tissues because the iris and the other tissues are closer to you. Small capsular opening, because it's a blind technique, you never know what's the adequate size of opening that you're making. Retained lens matter is very probable because the pupil is small and the iris can hide or clandestine small little particles of the nucleus as you're trying to emulsify them. And if you have a toric IOL to be placed, and 45% of our practice now is toric, so if you have a toric placement, then the alignment becomes difficult in the presence of a small pupil. Mechanisms in pseudo-exfoliation syndrome, the dilator and sphincter muscles have a deposit in the stroma, and that causes an atrophy of these tissues. They don't respond to medications as normal iris does. In IFIS, there is a dilator muscle atrophy, and it causes a hypotony. In synechia or membranes, pupillary membranes, cyclitic membranes, they mechanically restrain and do not allow the pupil to dilate. We'll see how to handle that in a moment from now. Age-related, there is a generalized tissue atrophy that occurs everywhere, in the capsules of joints, to the brain, to the iris muscles as well. And in diabetes, you have metabolic changes occurring in the sarcomeres, which also prevent a pupillary dilatation properly. The resurrective measures, you have pharmacological agents, pre-operative NSAIDs, intraoperative agents, combination of different agents that work. But in select cases, if you have mechanical restraint or very, very rigid pupils, none of these pharmacological agents work. High molecular weight OVDs cause a mechanical dilatation, but that stays for a very short while. And if you can finish off your work before the pupil constricts again, fantastic. Otherwise, you have to continuously refill the AC. Cyclitic membrane, if it is there, it has to be peeled off. We'll see how to do that. And of course, the expander devices. And the last but not the least resurrection measure is not to use anything and try to manage the nucleus with that small pupil. Let's take up cases now. This is a patient who has got a long-standing history of uveitis. As you can see, the pupil's not even visible, and the cyclitic membrane is there all around. So it needs to be that there's a hole that needs to be punched first, and then with the Simcoe, it was extended. The moment the cyclitic membrane is peeled off successfully, you will have a little bit of bleeding from the pupillary margin. That, in fact, is an indicator that shows you that the pupillary membrane has been effectively removed. At times, removing these membranes just restores its geometry. It becomes more circular so that you can implant the devices. At some other points, however, peeling the pupillary membrane actually causes very effective dilatation. You might not need any device after that. So this is one such case wherein the pupillary membrane was removed, peeled off from the margin, and look at the way it dilates after that. So the mechanical restraint, the moment it's removed, it dilates very well in certain cases. So we should always try to do that. Coming to devices, this is an age-old device which a lot of times we had used in the past, but not anymore. I don't use it anymore at all. The iris hooks, because they cause an unpredictable tear in the sphincter pupillary muscle. So post-operatively, this pupil never, in fact, restored their geometry, and the sphincter function is essentially lost. Many people use a fifth hook subincisionally. I don't do that. But the important point here is it's a good idea to place all the hooks first into the AC and then try to engage the pupillary membrane one by one. That way, you will get your adequate size, and you would not overstretch any tissue, causing a tent in the peripheral portion. The Milligan ring is a 5-0 polypropylene, the go-to device, at least for me. The technique of injecting it is the distal scroll should be engaged first at the distal side. The side scrolls, if are engaged simultaneously while the ring is being engaged, it is fantastic, because then you have only one scroll left which you can engage from the other side. And then after all the scrolls have been engaged, it has got an 8-point fixation. Fantastic device indeed. And once they're all engaged, you can reshape the pupil and bring it back to the central point for your convenience. The Gupta's ring is an Indian counterpart of similar design. The only difference with this is you need a 2.8 millimeter section for this device to go in. It doesn't go through a 2.2. And then the other thing is, it has a joint in one of the flanges. You can see that on the left-hand side, and that joint sometimes just snaps open. So just have to be careful. And it's not as malleable as a Mulligan, so engaging it is slightly more difficult, but it does the job and is more economical when the price point comes in. This is another Indian modification, our very own Shubenda. This is a B-hex, which gets in through a 9/0 nylon is the material out of which it is made. Very slender device, and you have to tuck alternate flanges underneath the iris. The only limitation this ring has is it does not work very well when the pupil is very rigid. So if the pupil is very rigid, you have to mechanically stretch it first and then apply the ring to get your adequate size of pupil. This is the Visitech eye ring, which has come up recently, and the material here is polyurethane, which is a much softer material. Just like the Mulligan, it needs to be pulled into the plunger first, and then it has to be delivered into the anterior chamber. And then after it is delivered into the anterior chamber, one by one, all the angles can be engaged. The advantage that I found with this is that it maintains a more circular pupil than the other devices. So the shape of the pupil is more circular, and after its removal also the pupil somehow maintains its circularity. But finally, all that being discussed, the final thing is maintaining or managing the nucleus without any device. Because all these devices, since they stretch the pupil, the perfect geometry and the sphincter function, the aperture function is never restored to its normal capacity in the post-operative period. So whenever we can, we should be trying to manage the nucleus without attaching any device to it. Nothing much needs to change on the parameter front. As you can see, the IOP still is maintained at 20. There's a pretty hard nucleus. The pupil is small. You just need to understand that the business area is right at the center, and you don't need to go chasing the nuclear pieces, and they just come into you. There's an unedited video, and I just wanted to show you that it's not very difficult to manage the nuclei, even in the presence of soft nuclei, in the majority proportion of our cases. So whenever we can, we should. Thank you so much for the opportunity again.